Indian Economy Series 3 Inequalities in Social Development. Inequality, Health and Other Social Factors. Inequality meaning, the United Nations describes inequality as a state of not being equal, especially in status, rights, and opportunities. Inequality can be broadly classified into economic inequality. Economic inequality is the unequal distribution of income and opportunity between individuals or different groups in society. Social inequality, it occurs when resources in a given society are distributed unevenly based on norms of a society that creates specific patterns along lines of socially defined categories. Example, religion, kinship, prestige, race, caste have different access to resources of power, prestige, and wealth depending on the norms of a society. Both these categories are deeply intertwined, and inequality of one type affects the inequality in another. Example, social inequality due to gender has a large impact on the income of women. Dimensions of inequality in India. Gender. The Global Gender Gap Report 2018 ranks India at 142 among 149 countries. 4 parameters for measuring gender inequality are economic participation and opportunity, health and survival, educational attainment, and political empowerment. Gender wage gap is highest in India according to International Labour Organization. 1/4 women are paid 34% less than men. Women comprise over 42% of the agricultural labor force in the country, yet they own less than 2% of its farmland, according to the India Human Development Survey, IGIDR. Caste. India's upper caste households earn nearly 47% more than the national average annual household income. The top 10% within these castes own 60% of the wealth within the group in 2012, as per the World's Inequality Database. Ethnicity. Tribal communities in India have been identified as ethnic group on the basis of their unique culture, language, dialect, geographical location, customs, etc. The National Family Health Survey 2015 to 2016 NFHS 4 showed that 45.9% of ST population were in the lowest wealth bracket as compared to 26.6% of SC population, 18.3% of OBCs, 9.7% of other castes. Economic inequality. The 2019 report by Oxfam, titled Public Good or Private Wealth, showed that India's top 10% holds 77.4% of the total national wealth, while the top 1% holds 51.53% of the wealth. The bottom 60% population holds only 4.8% of the national wealth. 13.6 crore Indians, who make up the poorest 10% of the country, have continued to remain in debt for the past 15 years. Inequities in health outcomes. High degree of inequity in health outcomes and access to healthcare services exists in India. Identifying the deprived areas, vulnerable population groups, including special groups, through disaggregated data is a first step to address the existing inequities in health outcomes between and within states in India. Even in states where overall average are improving, marginalized communities and poorer economic quintiles of the population, especially in remote and tribal areas, continue to fare poorly. For instance, fully immunized children aged 12 to 23 months in Orissa were only 45% in scheduled tribe as compared to 62% for the state. Corresponding figures for skilled attendance at birth are 26% and 51%. Below table indicates the state in India who have performed well in health outcomes and also the one who had faced greater challenges. Concerns in quality of care. The quality of care determines its effectiveness. For example, the over 90% of pregnant women received one antenatal checkup, only about 69% received the mandatory 3 antenatal checkups. Similarly, for institutional delivery, standard protocols are often not followed during labor and the postpartum period. Sterilization-related deaths are often a direct consequence of poor quality of care. Accreditation and certification through a voluntary process are nascent methods introduced to determine standards of a particular health care unit. Also, the Indian Public Health Standards (IPHS), revised in 2010, lay down the essential and desirable requirements for service, building, equipment, manpower, and drugs for public health facilities across various levels. Performance in disease control programs. India's progress on communicable disease control is mixed. Polio has been eliminated along with maternal and neonatal tetanus and leprosy, though significantly reduced, is stagnant at current levels of new effectiveness case and disabilities. Kala Azar and lymphatic filariasis are expected to decline below the threshold, except in a few blocks where the prevalence is relatively higher. In AIDS control, progress has been good, with a decline from a 0.41% prevalence rate in 2001 to 0.27% in 2011. But this still leaves about 21 lakhs persons living with HIV, about 1.16 lakhs new cases, and 1.48 lakh death in 2011. In tuberculosis, the prevalence is still close to 211 cases, while mortality is 19 deaths per 100,000 population. The increasing multi-drug resistant tuberculosis cases pose serious challenges. Development under the National Rural Health Mission. Apart from certain inequities mentioned above, some developments have been observed in the healthcare industry. The National Rural Health Mission led to a significant strengthening of public health system. It brought in a workforce of close to 900,000 community health volunteers. The Ashas, who aided in bringing the community closer to public services, improving utilization of services and health-seeking behavior. The NRHM deploy over 18,000 ambulances for free emergencies transport of 1 million patients monthly and added over 178,000 health workers to the public health system. NRHM as an instrument for strengthening state health system. The National Rural Health Mission was intended to strengthen state health systems to cover all health needs. The progress, however, remained confined to a few indicators only, like mortality and disease prevalence. Urban health, rapid and unplanned urbanization has led to massive growth in the number of the urban poor, including migrant population. This section of the population has poorer health outcome due to adverse social determinants and poor access to healthcare facilities, despite living in close proximity to many hospitals, public and private. As a matter of fact, primary healthcare in many urban areas requires considerable strengthening. The National Urban Health Mission, sanctioned in 2013, has a strong focus on primary care, especially for urban poor and vulnerable populations, by strengthening primary health care through additional ANMs, urban ASHAs, women health committees. Healthcare industry. The private healthcare industry is complex. It includes insurance and equipment, which accounts for about 15%, pharmaceuticals over 25%, diagnostics about 10%, and hospitals and clinics care about 50%. The private healthcare industry is valued at $40 billion. The current growth rate of the healthcare industry at 14% is projected to be 21% in the next decade. The government has invested heavily in the last 25 years in building a positive economic climate for the healthcare industry. Amongst these measures are lower direct taxes, higher depreciation in medical equipment, income tax exemptions for 5 years for rural hospitals, and custom duty exemptions for life-saving equipment. Public health expenditure rose briskly in the first few years of the NRHMs, but at the peak of its performance, it started stagnating at about 1.04% of the GDP. The failure to attain threshold minimum levels of public health expenditure remains the single most important constraint. While it is important to recognize the growth and potential of rapidly expanding private sector, international experience, as evidenced from the Table 2, shows that health outcomes and financial protections are closely related to absolute and relative levels of public health expenditure. Despite years of strong economic growth and increased health spending by the government in the 11th five-year plan period, the total spending on healthcare in 2013-14 in the country was about 4.02% of GDP. The government spending on healthcare in India is only 1.15% of GDP. This is 3.8% of total government expenditure and accounts for 28.6% of total health spending. This translates in absolute terms to Rs 1,042 per capita at current market prices. The situation analysis forms the backdrop to the National Health Policy 2017, which envisages to address the urgent need to improve the performance of the health systems within the global context of Sustainable Development Goal.